Good morning and welcome to the Louisiana AAP Pediatric Gumbeaux webinar series. We're going to go ahead and get started with our housekeeping. As you come in, please go ahead and share where you're based in the chat so that we can get to know you. In order to be more accessible, we have enabled closed captioning in this webinar. Look at the Zoom toolbar to turn on closed captioning in your view. You may need to click the three dots that say more to see the closed captioning option. Our speaker for today, Dr. Warrier, has no relevant financial relationships. Okay, without further ado, I will introduce our presenter. Dr. Raj Warrier is Professor Emeritus and Clinical Professor of Pediatrics at LSU Health Science Center and Children's Hospital in New Orleans, as well as numerous other appointments. He's had a storied career in pediatric hematology oncology, including many presentations and publications to share his work with others in the pediatric world. Dr. Warrier is joining us today for his second webinar in the Pediatric Gumbeaux webinar series. I will now pass control over to Dr. Warrier to begin the presentation.
Thank you. Okay. Can you guys see my slides?
Yes.
Julia? Okay, thank you very much. Thank you, Julia, for calling me again. And I know I love to teach. I've been doing this I've been a pediatrician 53 years now, so almost as long as your dad, so long time. I love to teach, and this is a very interesting topic. I'm going to be covering it from both pediatrics and oncology point of view, and I'm going to try to stress something very important, that as a doctor, as a student, as a resident, you always try to do some research, write some papers, makes a big difference. So I'm just trying to show you how a simple case report by a resident from our floor from Children's Hospital became a very important paper later on in life. So I work now at Oxnard. I'm part-time. I work 75% of the time. And just remind myself that I was a fellow in the 1970s. This is a doctor who taught me to do lab research. At that time, I was looking at lymphocytes and EBV. I learned about lymphocytes at the time. This is my first fellow from New Orleans, Louisiana. I don't know if any of you remember him. He was 1980s. He retired. I'm still working. And this is one of my newer students from Tulane who's just wrote a paper on EBV with me. And EBV always scares me. This is like a very scary infection. We take it very lightly by the hematology I've learned to be worried about EBV. If I speak too fast, just stop me. And also I see a lot of people who can ask me questions anytime you want. Just stop me, interrupt me. I don't mind being interrupted at all. So we're going to review the pathophysiology of EBV, listen, hematological complications of EBV, and discuss about our paper that we wrote about the PTLD and EBV. This is my team at Oxford right now, and they've been very cooperative. They let me travel all over the world and look after my patients. Just a couple of words about oncology in Louisiana. I've been here for 40 years now. So I'm very proud of one of these. This is called the Camp Challenge. It's a camp that we organize for children with cancer. I would like all of you to remember this is open for everybody in Louisiana and Alabama. This camp started by 3 or 4 of us from LSU and Children's at that time, but now it's across the whole state. It's completely free for patients and a sibling. For 1 week, held in Alexandria. It's a very popular camp. I always remember this picture because this is one of my first patient. I came to Louisiana in 1983, if I remember right, 83. My first patient, leukemia here. He's cured of leukemia. He works in Lake Charles as a police officer. So many, many years of being here. And this is what I want to stress to if anybody is listening, especially if there are any junior faculty or residents. Stacy Drury was one of our medical students at LSU at that time. She later on became a MD, PhD, and a professor of pediatrics at Harvard Medical School. That time we had a patient, and the patient later on, a little patient with leukemia, was in very unusual symptoms. And after some difficulty those days, we diagnosed it as EBV infection and a small like lymphoma, likely as a brain, was cured and did well. So we wrote an abstract and a paper. Actually, this is Dr. Rajiv, who was a fellow with him at that time. This is Dr. Oski, famous Dr. Oski from Hopkins was with at that time. This is Dr. Rajiv. These are students again who helped with the paper. I like to make them all write papers and abstracts so they become faculty later on. This guy was LSU met Pete Russell wrote first paper with me. Now he's a professor in Miami. So this is the paper ended up. So that particular paper was published almost 20 years ago. Then in 2003, I had a call from Israel. Dr. Elitzer called me, Dr. Warrier, can I talk to you? I said, why? I said, 20 years ago, you wrote this paper on leukemia and patient with the mass in the brain, turned to be EBV. We have researched now across the country, the world, and we have about 20 patients of similar type. Can we include your 2 cases in this listing? So it became a very popular, very well-written paper in Blood in 2023. Because we have patients from St. Jude's, UK, USA. We had a couple of patients from Louisiana. That's how this article came. So just to remind people that if your case reports often looked down upon, but that's how things start. Most syndromes, most things start by somebody writing a case report. So I'm very proud of my fellow and the rest of who wrote the paper. So coming back to EBV, I know that you're all faculty. I'm like, should not be asking many questions, but anybody wants to know what kind of doctor was Burkitt? I said, Dr. Bakuta. Oh, Dr. Gottschalk. Hi, Dr. Gottschalk. How are you? Carlos. Okay. Anybody wants to make a guess who was Dr. Burkitt? What kind of doctor? Was he surgeon, a pediatrician, an ID doctor? Anybody? He was a surgeon. Okay, he was a surgeon. So unusual for a surgeon. He discovered this Burkitt's lymphoma in Africa. I think it's in Malawi. I'm not sure. In Africa, and these are all low-grade lymphomas in Africans and they found this Burkitt's lymphoma. So how many of us do you think have had EBV already? If you're in the US, by the time we're about 18, 20 years of age, almost 90% of us had EBV infection. Could be latent infection, a more prominent infection, but almost all of us carry EBV. And the classic lymphocyte is called the atypical lymphocyte. It's called Downey's lymphocyte. So a few things that are all very, very well known about EBV. So Burkitt was a surgeon. It was almost all of us carry EBV, at least about 90% in the US. And then it's called Downey's cell. Just a few things about herpes virus and EBV virus. It's a gamma herpes virus, EBV1 and EBV2. And we see roseola very commonly in pediatrics, well-known viral infection. It's actually caused by HHV6. So it's also belongs to the same viral group as EBV. CMV and HSV also belong to the same group. So when you get herpes simplex virus in newborn, it's also caused by same group of viruses. And as I told you, 90% of adults are positive for antibody. Primary infection may be earlier and less symptomatic in less developed countries. So if you're in India, by the time you're 5 years of age, about 90% have had EBV. And it's been well proven that if you get EBV infection in younger age group, infection much milder, almost like a cold and go away. But as you get older, especially in the US and UK, etc., when you're 10 years, 15 years, you get much more serious and severe. So older children have more severe infections. A couple of years ago, actually in 1958, was when Burkitt discovered lymphoma in Uganda. Dr. Epstein was a pathologist who had heard his lecture was a unique tumor. So he went back to England. I forgot, I think it was in London, University of London, I forgot which university, but he started studying this tumor histologically, electron microscopy, and found this particular virus particle and published in 1964 with Michael Epstein, A. Shong, and Barr. And then in Children's Hospital of Philadelphia, in the 1960s, they developed an antibody against this particular virus. And in 1967, one of the workers in the lab had a cold-like picture, fever. They did tests and found this antibody to diagnose EBV. The first way you could document EBV infection by checking the antibody in a person. In 1968, they developed the IgG, IgM antibodies for diagnosis. That's what we use even today for diagnosing EBVs, IgG, IgM antibodies. If anybody has any questions, please stop me anytime you want. Okay, so I'm just going on. Tell this overall. Okay. So a couple of little pathological things about this infection. It's a primary infection, usually in the pharynx. It enters viral entry through the epithelial cells, then enters the lymphocyte. So lymphocyte is primary abode, also permanent abode. and it transforms the lymphocytes. That's what we see as atypical lymphocytes into almost like a blast-like cell. In fact, I'm a hematologist for many 48 years now. You see a lot of patients referred to as abnormal cells in the peripheral smear, possible blast, turns out to be atypical lymphocytes, but it can be very blastoid looking. And so it proliferates the lymphocytes. So your good immune system, if your lymphocytes are functional, CD8, CD3, they become quiescent, but they never go away. They get attached to not the episome of the nucleus and stays there forever and ever. So if things change, if you get malnourished, if you get HIV infection, if maybe some other we don't know unknown complications, they can reactivate, enter back into the body and give you malignancy and other symptoms. So so once you get EBV, all of us carry it forever and ever, just like holding with HIV, it doesn't go away at all. Very important, keep that in mind. It's called a kissing disease because it's transmitted by saliva. So you can get it from cups and tablespoons, etc. Also, genital secretions, we don't consider, but it can be transmitted sexually also. Blood transfusion, not anymore, but it's a risk in the patches like malaria, syphilis, etc. Blood transfusion can transmit EBV. Transplants, we're going to talk about transplant later on, especially solid organ transplant and bone marrow, well known to transmit EBV. I told you about viral tropism, that enters lymphocytes, epithelial cells, and stays there in the lymphocytes. And lymphocytes, the normal functioning lymphocyte, they can take care of it, but can't destroy it completely. And latent phase, it stays the memory cells, it's a lymphocyte cell. I don't want to go in detail, but I myself don't know this, but there are a lot of specific markers, not only antibodies, but even genetic markers in different types of these phases. So we'll come to that in a few minutes later on about cancer, but there are lots of genetic and immune markers that are present in each phase of the cell that predispose certain things. As a replication, it switches from latent to acute and lytic cycle. And there's a cascade of gene and immune reactions. This is a classic EBV that we see. Patients come with fever, exudative pharyngitis, and tonsillitis. And for those of you old enough in the audience, and I remember before we had a lot of testing, somebody would give child with a fever and a sore throat, penicillin or amoxicillin, classically amoxicillin, they would come with a rash. It's a classic rash, and get hepatosplenomegaly, big lymph nodes, and of course the atypical lymphocyte. And with diagnosis used to be by the monospot test. I want to remind, I'm sure in the audience people now know that, especially in children, monospot is totally unreliable, not very useful at all. Even older people, unless they have classic symptoms, monospot will be negative, can be falsely positive. So I think most labs have stopped doing monospot tests. They do EBV, IgG, and IgM. And if you want to be more specific, or especially people with transplant, etc., you can do a BB viral PCR and quantification. Treatment, very unique. EBV is extremely smart because unlike CM, other things like HSV, etc., there is no treatment for EBV. And I learned during this preparation of this talk that in the talk to infectious disease people, EBV lacks a particular enzyme that most of these drugs work on. And this virus is so smart, it doesn't have this enzyme, can be activated or destroyed, so it can't kill the cells. It's a very interesting concept that they lack a particular enzyme and they can't be treated. So the manifestation multiple, I won't go in detail, you guys know better than I do, can be. So I remember Dr. Steele telling me about a patient with EBV causing blindness, can cause photophobia, encephalitis, meningitis, classic was the throat and tonsils, lymphadenopathy. We have seen patients with bull neck, so big that can cause compressive trachea and the oropharynx, respiratory coughs, splenomegaly. I seen one patient at children's where rupture of spleen, actually as a football player who refused to listen to advice, played football and ruptured his spleen, and you can get systemic symptoms. We'll talk about malignancy in a few minutes. This is a picture actually I got from the adult people. This patient with exudative tonsillitis. This teaches about this dirty looking exudate and big tonsils. This again from adult is called hairy leukoplakia, known with EBV, especially in immunocompromised people. This is again the older people with a marked tonsil enlargement with compression of the oropharynx, in marked hepatomegaly and splenomegaly. So in most cases, if you're normal immunity within 2 to 3 weeks, symptoms resolve and they're fine. Again, massive enlargement of the pharyngeal area. You can get mediastinal lymph nodes. This is a classic situation of bull neck. Sometimes they will require steroids, or in rare cases, in intubation. This is the classic cell called a ballerina skirt. See that these cells are compressed by the red blood cells form called a ballerina skirt cell. Very classic for EBV is a transformed lymphocyte, but not a blast. But if you show it to a non-pathologist, non-hematologist, may look like a blast even. Okay, so be very careful. A lot of people misdiagnose both ways as blast. And again, just remind you, I'll present the case later on. It can easily look like malignancy. In fact, there have been many cases I've in my own experience where by good pathologists, even if you do biopsy for patient EBV, send it to them, it looks very much like Hodgkin's lymphoma. So this is a classic triad is pharyngitis, adenopathy and fever, and it could be lymphoma also. But usually turn non-tender lymphadenopathy, fever is more prolonged, and CBC may be abnormal. So what else can this EBV cause other than our classic infectious disease picture? It causes a lot of complications, malignant and non-malignant. I told you about the bull neck with upper airway obstruction, varicose cirrhosis, tracheostomy. We have seen patients with autoimmune hemolytic anemia that come with Coombs positive hemolytic anemia. We've seen quite a few cases of autoimmune thrombocytopenia. In fact, a lot of ITPs that we diagnose could be EBV-induced that we don't know about. So thrombocytopenia. Aplastic anemia, I'll present the case in a few minutes. Hepatitis, again, EBV can come with elevated liver enzymes and cholecystitis. Myocarditis, EBV is a bad cause of myocarditis, along with the parvovirus and other viruses. EBV can cause myocarditis, cardiomyopathy, rupture of spleen, I told you about. Of course, chronic fatigue syndrome, especially in pediatrics, is a big issue. People don't get better, they go on for a long time. And some cases, meningitis, encephalopathy also. Okay. Is there any questions? Are you all with me, guys? Dr. Tat, are you with me? Am I too fast for you? No? Kunjan? I see Jennifer is not.
You
Okay.
could slow down a tiny bit, but you're doing great.
Okay, I won't slow. I'll stop breathing, so I'll slow down a little bit. Okay, very good. So, going to the chronic active infection, there's more common Asians and South Americans. Due to EBV non-NK cells and T cells also, and clinically they can have adenopathy, liver dysfunction, splenomegaly. They can have fever, rash, and CNS. And again, increased levels of pro-inflammatory cytokines. This is what we sometimes call the. And in these people with very chronic active EBV, almost looks like a PTLD. They may require aggressive treatment, including EBV-specific cytotoxic T. We'll talk in a few minutes, but EBV cytotoxic specific T cells. It's a patient of ours I saw about maybe 6 years ago. It's a little boy who came with a progressive pallor, bruising, no organomegaly adenopathy, was markedly anemic, you can see. Was neutropenic, leukopenic with neutropenia and low platelets. And no spleen, no liver. So classic aplastic anemia. With aplastic anemia, normally most of the time is with no specific etiology. But in this case, we do a lot of viral studies like hepatitis. This is curtain of EBV. And the bad part is with EBV-induced aplastic anemia, the prognosis is not very good. So this child had a bone marrow transplant at that time at Children's and still did not do very well, and had actually passed away. So we can really look at the bone marrow. Looks like my brain as you grow older, a few cells left behind. EBV-induced, so can be quite severe. EBV-induced aplastic anemia, EBV-induced thrombocytopenia, and malignancy with EBV. We all of us know about from medical school about Burkitt's lymphoma. There are two kinds of Burkitt's lymphoma: American Burkitt's lymphoma and African Burkitt's lymphoma. So American Burkitt's is not very often positive EBV, but Burkitt's almost always positive. Burkitt's lymphoma is usually more slow growing. It's endemic in particular parts of Africa, and 95% EBV positive. American Burkitt's not as often positive, but most rapidly growing. In fact, for the pediatrician audience, it is the most rapidly growing tumor in pediatric practice. Within 24 hours, it doubles itself. So I've seen pediatricians who have seen patients 5 days ago, abdominal pain, didn't feel anything, come back, the patient has a huge mass, can go very rapidly. So PTLD, so again, that's what we're going to talk about later on today, is post-transplant lymphoproliferative disorder, PTLD. I'm sure all of you have seen one or two in your life, people with post-transplant from kidney especially and liver. So also can cause Hodgkin disease. We don't think EBV and Hodgkin, but especially with people immunocompromised, there are at least a couple of patients with Hodgkin disease and HIV patients. Of course, all of us know what nasopharyngeal carcinoma, definitely related to HPV, EBV, also EBV, Both of them can cause nasopharyngeal carcinoma. Usually HPV causes oropharyngeal and EBV causes nasopharyngeal. There have been recently some reports of gastric carcinoma, and they found EBV genome in that also. Then for those of you who are immunology or hematology pediatric, HLH, immunocompromised family syndrome called Duncan syndrome. So if you got a person with Duncan syndrome, have EBV infection, they can get X-linked lymphoproliferative syndrome, like hot lymphoma. Now, what we're going to report today is about ALL lymphoproliferative disorder. So PTLD and ALL, the first report that we made in 2023. Again, I love to teach, and I know I've been doing this for 50 years. Actually, I'm just counting the other day. I've taught in 34 countries. So I love, this is my morning report group of people from Oxnard. So one of these guys presented this case one morning. Sometimes we have good breakfast, but they don't no breakfast. Okay, I want to present, inform the mother, a reliable historian. This child is in the pediatric emergency room. The 17-month-old African-American boy with trouble opening the right eye. He had fever for 1 day, cough and congestion. The face and the right eye was not to be drooping. So a fever, rash, drooping eye. This little boy who had biliary atresia. Unfortunately, his cypress did not work. I had liver transplant done 7 months ago. So biliary atresia, Kasai procedure, status transplant on immunocompromised immunosuppression, pretty strong immunosuppression, and also acyclovir comes with this complication of fever, ptosis, and again post-liver transplant, multiple medications. So child had high ESR, CRP, and normal procalcitonin. Anybody wants to give me a guess what's going on? Any test you want to do? So this child, since he had neurological symptoms, the scan, you can see here, see. I don't know if anybody's ID is in the group, but when you see this in a patient, we worry about toxoplasmosis. And you can also worry about the possibility of lymphoma or PTLD. This patient had we did EBV titers, they were very, very high. And EBV viral genome, and the biopsy turned out to be a post-transplant lymphoproliferative disorder. Very classic. Enhanced lesion. Could be toxoplasma, could be PTLD or lymphoma. I just want to give since a pediatric differential diagnosis, anybody wants to guess what this could be? This is not lymphoma, is a patient who ate uncooked meat and got this lesions with seizures in it. Anybody in the audience? You guys are very silent. Don't worry about being wrong, just make a guess. Multiple cystic lesion in the brain with seizures, and a person who ate some uncooked meat. Like this neurocystic cellulose, can cause seizures. So the cystic cellulose, tapeworm. Anyway, this particular patient had EBV versus lymphoma, very high EBV titers. So what do you do for treatment? First, stop the immunosuppression. The transplant people don't like that, but decrease the immunosuppression and see if it works. In some cases, that can work. Otherwise, you have to add on surprisingly more chemotherapy, especially drugs like methotrexate and rituximab. At this point in time, the standard treatment is rituximab. Stop immunosuppression. If you can't stop it or if it does not work, add rituximab. So we're going to have a post-transplant lymphoproliferative disease called PTLD. Again, the reason I'm presenting this to pediatrics that nowadays, all of you in practice are going to be seeing a lot of patients with oncology problem. There's very good data that by year 2030, 1 of every 200 patients that you see will be a patient who had leukemia, lymphoma, cured. And because we're curing so many of them, they're coming back to see to follow up. You can't follow up all of them, so they're going to come to see you. So keep this in mind. If you're any kind of chemotherapy, any kind of cancer, risk of second cancer is very high. Okay, so between 3 to 8%. So you have to keep in mind when to call us again if there's a problem. So PTLD very classically is more high in solid organ transplant. It's much more common in highest is initially in multi-organ transplant, then comes heart transplant, liver transplant, kidney transplant, last in bone marrow transplant. Reason being that in those transplants, they have very, very strong immunosuppression for a very, very long time. Leukemia, bone marrow transplant, luckily, we give it for a very short period of time. Then, depending on the medicine that you use, some of them are more severe, more cyclosporines, that is more severe risk of PTLD. They require very close clinical lab monitoring. If you're following the as pediatrician, any change in clinical course, especially failing to thrive, fever, neutropenia, etc., to worry about second malignancy. So role of EBV in viral quantification during transplant, immediate post-transplant, and they are immunosuppressed. A lot of them monitor now EB viral quantification. If it's diagnosed, suspected, you can do imaging, CT, MRI, and call the oncologist. So this is a case that our case is a little boy from Lafayette, Louisiana. Actually, the dad had HIV, so we were always concerned about the child. But he had leukemia, classic pre-BALL, came to at that time LSU in children, at standard risk, good prognostic leukemia. We started pediatric oncology group study, very good vincristine, elasparaginase, prednisone, 6-MP, standard protocol. Did very well, went into remission, did well, but during the last 5 months of treatment, he would call us from Lafayette, Dr. Warrier, my father got fever. First couple of times, said, let's just watch and see. But then 2 episodes fever, very high fever, prolonged, had adenopathy, lymphadenomegaly, had cytopenia. We worked him up for everything, all the usual things, blood culture, bone marrow, nothing was found. So I remember the boy used to complain, Dr. Why are you sticking me each time when I got fever? But then he came with a fever, adenopathy with severe headaches and signs of intracranial pressure. That time we did a CT scan, showed a cortical mass. So Dr. Joseph Nedal, who was a neurosurgeon at that time, did a biopsy. The diagnosis possible lymphoma. So Dr. Pathologist saw the patient. They thought possible lymphoma. And they were not very sure what kind of lymphoma it was. It didn't look like non-Hodgkin, didn't look like Hodgkin's. They call it polymorphic lymphoid hyperplasia. This is a few years ago, with not a lot of viral study, but we did the EBV genome studies, and EBV thought to be EBV. They found EBV genome in the tumor. So this particular child, about to finish chemotherapy, had done very well so far. So we took a risk of stopping chemotherapy and just watching him. And lo and behold, child got completely better. The lesion went away and never came back. He's still alive, almost 20 years later, doing fine. So my resident and my fellow wrote the case up. My patient, unfortunately, being a oncologist, I was mad because apparently there's a rule at that time that more than 10 years, they can throw the records away. I couldn't find my old chart. So, but it's a different patient, but you can see here again, similar lesions. It's a different patient, but okay, so intracranial. So you can see the same lesions. Yeah? So patients with EBV-induced PTLD, intracranial lesions, and surprisingly, no other lesions elsewhere. So this is child diagnosed EBV, PT, lymphoma. At that time, we reported the patient and forgot about it because he did so well. Other tumor that you can get with EBV, this is a classic non-Hodgkin's lymphoma or Burkitt's lymphoma. These are in African Americans, more common, very often in the jaw, not very fast growing. I'm sure if you remember pathology from olden days called the starry sky pattern. Look at vacuoles, a very classic translocation, 8-14 translocation. Lymphoma is called Burkitt's lymphoma. You can get usually most of the time it is non-Hodgkin's Burkitt's B cell. Girl that we saw also a mass in the neck. It's got ptosis or Horner syndrome, non-Hodgkin's lymphoma. So one patient that we saw, is uncommon to find this patient with T cell lymphoma who also had EBV, but we don't know whether EBV was from earlier, was there a tumor or not. But this there are reports of T cell lymphoma also potentially caused by EBV, but not very well proven. Okay, this is a patient intestinal lymphoma, another site for lymphoma again. This is again some other lymphomas in different parts. Now mostly non-Hodgkin's. This is not my patient, but early reports other patients with PTLD. So what all can you get with EBV? And what have you seen in New Orleans, Louisiana? We had a patient with post-cardiac transplant with PTLD, especially in cardiac transplant because the immune response is very strong for a very long time. Risk of PTLD is higher. We had one case of juvenile CMML with EBV. We had a few cases of renal transplant with non-Hodgkin lymphoma. We had one case of Hodgkin's with HIV, and also we talked about Duncan syndrome. And this is a patient with had epistaxis for a long time. We looked up for the nose found a mass at nasopharyngeal carcinoma. She was only 12 years old. She had both HPV and EBV. So I want to remind you guys, especially pediatricians, please remember to give HPV vaccine to everybody. In fact, we said 9, 10 to 20, but I know ID doctor friend of mine who's 40 years old, still to the vaccine. Okay, so I think it's a well-known cancer prevention vaccine. Anybody and everybody should take that. Okay, HPV vaccine. So Hodgkin disease again with EBV. And I want to present this one case just to show you how fallible we can be, how wrong we all can be. This is a patient, 16-year-old healthy Caucasian male, was in urgent care clinic. I think that's the most dangerous place in the whole world to go to, but especially for children. So she had history of tonsillectomy and adenoidectomy at 6 years, had fever. So they examined him, had some pharyngitis, they did a strep culture, an NP swab, and I don't know, they start all of them on augmentin and steroid injection. So he was not feeling better. I went to see an ENT doctor because the mom was a nurse, and they thought I was swollen and red turbinates bilaterally with serious discharge. CBC was normal. CBC was normal. CMP was normal. PTPT was normal. So the ENT surgeon did flexible endoscopy and found large bilateral adenoid masses, surface covered by mucus. I think they were concerned about the largeness of the swelling, the location, and was not getting better with the antibiotics, so they did a biopsy. And 3 days later, biopsy was done. Histology was Hodgkin disease. It was seen at our hospital, reviewed at Mayo Clinic, confirmed with Hodgkin disease. And they, adult oncology a little slower than pediatric oncology. They take time to schedule things and all that. So I said, come back in 3 or 4 days. We'll do a possible resection, staging, etc. Mom was a nurse and happened to be from near La Place, Louisiana. Happened to be a friend of our oncology nurse. Should not put the name, I'm sorry. But so she said, so they were talking, oh, why he's 16 years old, come to pediatric, let our doctor see you. And so 7 days later, he came to see us before he goes for the biopsy surgery, and he was feeling much better. No fever at all, eating well, with football player, no night set, no weight loss, no pruritus, no adenopathy, no neuropathy. And this eruption is gone and wants to play football again. So when I examined him, he had a couple of small nodes, fully mobile, non-tender, nothing too bad at all. This is a classic Reed Sternberg that we see. Again, but so we decided to told the mom we do some blood tests and find out. So CBC showed normal CBC, but peripheral smear showed lot of atypical, multiple atypical lymphocytes, and all the other patterns are normal. EBV titers are elevated IgG and IgM both. IgM also. So most likely, so we called pathology back again, told them this patient has come to see me, looks like EBV, can review the slides, patient is feeling much better. So both Mayo and our hospital said that it looks like maybe we made a mistake. So possible reactive adenopathy secondary to EBV. And then patient went home. He's now maybe 10 years later doing absolutely fine. So here's it's a good hospital, good pathologist, Mayo. So EBV can be extremely misleading, but very careful. So they can even see this Dorothy cells in the cells. Okay, here's again. So Reed samples are EBV infection. And we have talked about all these things already. So please don't discuss this. Very important mimicry. There have been review studies done about how the concordance, a lot of cases of discordance in these people. Okay, we already talked about chronic EBV infection. And as I said, more recently, we've got more markers. Now, I don't want to go in detail, but there are more immune markers, genetic markers that will help you differentiate PTLD from non-malignant lesions, EBV from, but those are all very difficult to do, not always very classic also. So diagnosis of PTLD, high interest suspicion, especially for following transplant, EBV genome monitoring, clinical exam for pediatricians. After exam, do CBC, LDH, uric acid, and if you suspect do a CT, then call hematology. Okay, so okay. I remember serial monitoring. There are some people who are transplant doctors who do this now. The EBV titer goes up, then they decrease the immunosuppression, look for complications. So I just want to go through our report. As I said, I'm very proud of my fellow. So if you look at all children with cancer, you're all going to be seeing these people who are cured of cancer. Please remember, between 3 to 8% get second cancers. Second cancers are more common in people who have gotten, especially those who got chemotherapy and radiation together. Hodgkin disease, brain tumors. Leukemia is relatively less common, but about 8% can get second tumors. Most of them are leukemias, brain tumors, etc. So bone marrow we looked at our patients across there's actually multiple groups in the country and abroad. We found 85 patients with non-Hodgkin lymphoma following leukemia, and we were able to study them, study their morphology, study their markers, etc., and find out how many had lymphoproliferative disease. But what happens, the normal survival for a normal leukemic child today, it's almost 90%. And earlier, as high as 75 to 80%. But for those people, PTLD, it went down to almost 65%. And the risk of second neoplasm went up higher than 3 to 8%, went up to 20%. So both these are, we think, probably because of the PTLD-related complication, EBV. So this is the patients in 12 collaborative studies, 85 children, and 5 years went down to 70%. We follow them up to 30 years. And PTLD itself causes about 15%, 13% mortality. So again, it's a very important complication of treatment of leukemia. I'm saying this because it's never been reported before. We thought ALL is very mildly treated compared to other tumors. There's no radiation involved, but even in that, there is risk of PTLD. So what I'm trying to teach pediatricians is that anytime you're immunocompromised, somebody with long-term for steroid, long-term methotrexate for any immunocompromised patient, the risk of PTLD, EBV reactive is very high. So treatment, most important, decrease or change the drugs. Antiviral not effective, especially ganciclovir not effective because of the lack of the enzyme. Chemotherapy, we use methotrexate or rituximab, more common. There are new biological agents. And this is a very important infusion of specific anti-EBV lymphocytes. It's been developed as marketable, but the market is available. You can use infusing specific anti-EBV T lymphocyte. And in the future, maybe CAR-T therapy, we'll be able to take the antigen of the leukemic cells, make specific lymphocytic antibodies, and infuse it back to them. But not as popular for this, but it's being used for leukemia. And a lot of treatments, research going on targeted therapy, get specific antigens and genes. And they're trying to have EBV vaccine. So far, it's not been successful. So there are treatment options available, but most important right now is rituximab and anti-CD20 is the most common. Okay. I won't go too much detail for you guys who are not oncologists, but a lot of new things are being tried. Again, treatment options, we're trying immunologicals, combination of treatment, adaptive immunotherapy, and a lot of new things are being tried. Okay. So I just want to remember, you got a few minutes left. I just want to remind you again for the pediatric audience that leukemia, cancer therapy changed dramatically. I trained 45 years ago. We used to use chemotherapy with vincristine, radiation, but now it's dramatically changed. We're trying to use more and more targeted therapy with less toxicity. So our aim is to classify them prognostically. If you have leukemia, is it a good prognosis leukemia, bad prognosis leukemia? If it's good prognosis leukemia, give less chemotherapy, less side effects, long-term survival, less complications. So a lot of it is now our time prognosis, age, sex, race, but now it's mostly molecular markers. There are a lot of molecular markers available. So based on that initial diagnosis, look for gene expression, find out gene variations, and even to predict remission. Again, I remember as a fellow, we would have bone marrow, count 500 cells, call them as leukemia remission or not. So, but now we've got markers that will pick up 1 in a million leukemic cell remaining behind. If they're remaining behind, in order remission, give more chemotherapy. If they're gone away, give less chemotherapy. So it's prognosis based. A lot of it is genomics, proteomics, metabolomics. So by the time, it's changed dramatically these days. So we're trying to give less chemotherapy for less, for this with good prognosis and avoid complication. So this is just a couple of examples from New Orleans of a little boy with in 1990s, he was diagnosed with chronic myeloid leukemia. I got the permission to show his picture. So 1990s, he diagnosed with chronic myeloid leukemia, little Indian boy. Those days for CML, only option of bone marrow transplant. And being an Indian with no family member available, he had no donor here or India, his chance almost zero. But during that time, they developed a new drug called imatinib sulfate. So in CML, the Philadelphia chromosome, it's called a particular translocation affected by this drug, works only on that translocation, only on that enzyme, only on that cell, causes no side effect. Not available to children. But his parents went to the FDA, went to the company, got special permission, got him on the drug. He went into remission. He's been in remission for 20. He just got married. You see how happy I'm to his marriage. So he's doing well. He's a lawyer from Harvard in New Orleans. Just to show you how dramatically things have changed. The patient would have died for sure with a transplant. and oral medicine, no side effect, is in remission. So we have found that for many tumors, finding them. Little boy was running a car in New Orleans airport the other day. He came running to see Dr. Warrior, I'm a patient with Hodgkin disease. Again, Hodgkin disease, when we were residents and fellows, we would give them chemotherapy, radiation, splenectomy, but now we do biopsy, make a diagnosis, and give them very targeted therapy with much less toxicity. So 95% survival, but much less toxicity. So it has changed dramatically because of diagnostic abilities, molecular markers, and targeted therapy. So there's some references. Some more references. Again, as I said, these are my students. I'll explain with, but there's some more references. But in short, I just want to remind you, this is a very common infection that we see, EBV. You often don't give a lot of respect to this virus, but this virus never goes away. It stays in your body, looking for an opportunity to come back sometime, and you're immunocompromised, and medications, and the malnourished, give you more trouble. But specifically EBV and many other viruses, we are very concerned about when they're immunocompromised. So is any questions, anybody? This is a picture from actually, this is a good story. This little boy that lymphoma is cured. So I was with all these clowns. Somebody came out, why are you not dressed up as a clown? So he said he's a clown anyway, and didn't dress up at all. So he's cured or he's working as a lab tech in LSU Shreveport. Okay, so in summary, EBV, common infection, usually harmless, but can be potentially dangerous, especially risk of second malignancies, immunocompromised people, altered senses. Anybody, any questions?
All right, so now is a great time to ask questions, share cases of your own, or start discussion. You're welcome to unmute and come off video or turn on your video to do that.
Yeah, I would like to sit around. I see Dr. Gotcha. I've not seen her for a long time. I would like to see her. Oh, sorry, what happened? Okay. Anybody? Dr. Bakuta.
Dr.
A lot of our patients before.
Bridges said, thank you for your years of service to children and their families and sharing your vast knowledge in these presentations. Dr. Sunny Bridges, apparently Varnado was her maiden name. And then Dr. Yeah. So any questions? Now's a great time to share about your own cases that might not have been exactly like this, but similar, and get some feedback from people. And I am dropping the announcements into the chat so that you can see to claim your evaluation and that kind of thing. Okay. I'm going to go ahead and go through our closing announcements, and if anyone has any questions, feel free to interrupt me or do the raise hand and I'll see that. Okay, make sure you claim your evaluation for today's webinar claim your credit for today's webinar by completing the link in the chat or by scanning this QR code. The evaluation form typically takes less than 2 minutes to complete and helps us to continue to improve our CME offerings. And our next webinar will be with our new executive director, Natasha Cheatham, about implementing motivational interviewing across your practice. And then finally, you can access more free education from Louisiana AAP on our YouTube channel or at our education page, which are both linked in the chat. The education page is laap.org/CME-courses. Okay, well, thank you so much. Anyone have any last minute questions before we give you back a few minutes?
No questionable characters.
Doesn't look like it.
Okay.
Okay.
Thanks, Julia.
Thank you so much for joining us, Dr. Warrior, and thank you, everyone. We'll be excited to see you in a couple weeks for our next webinar.
Thank you.
Thank you all.